Hello, and welcome to the University of Washington Cardiometabolic Echo Session 17. I'm Nicole Earhart, one of the adult endocrinologists here at the University of Washington. And today we're really excited to continue our cardiometabolic series with the speaker Bharti Shetye from St. Petersburg, Florida, who's a weight loss specialist. She's going to be talking to us today about FDA approved medications for weight management. Additionally, we have some great panelists with us today, including Paul Chakowski, who's an adult psychiatrist at the University of Washington. And we have Allison Ward, our psychologist, who's also an expert on diabetes and diabetes distress. We have Savitha Subramanian, who's an adult endocrinologist and also our lipid expert. And finally, we have Laura Montour with us today, who's our family medicine doctor and obesity specialist as well. So without further ado, take it away.
So I'm an obesity medicine specialist, and I've been practicing obesity medicine since 2006. So gosh, it's been 16 years. And I'm really passionate about what I do. And with the rate of rise in obesity prevalence, we need more people like Dr. Earhart and your team to help us dent this trajectory. Disclosures: I am on the board of trustees with the Obesity Medicine Association, and I have no financial disclosures. So I looked at the lineup of the Cardiometabolic Echo series, and absolutely sensational. And I was requested to talk on the FDA approved medications and the anti-obesity medication. So that is what we will discuss today. Recognize and discuss the indications, explain all the medications, discuss the common side effects, and be comfortable using the FDA approved medications for weight loss. Are we all on the same page? Are we all seeing the slides? Perfect, thank you. All right, so we all know over here that obesity is a chronic disease, chronic relapsing disease with treatment options. And I cannot stress the importance of all of us understanding that there are so many people out there, from patients and primary care physicians, who still believe eat better, exercise more, and you'll be okay. But that is so not true. So besides being specialists, we also need to advocate for our patients out there. Our rates have increased in the US since the 1990s. We are at 40% at this point of time, and we expect it to be at 50% by the end of this decade. So you're talking about 1 in 2 people having the disease of obesity, and that is a huge number. If you look at a graph to the right, the world is getting heavier and America leads the way. It's nice to be a leader, but not in these numbers. So we all need to work together and smarter. Thank you all. Right. The 4 pillars of treatment for the disease of obesity: nutrition, physical activity, behavioral modification, which I really believe is the most important one, and then treatment strategies, which could be medications and or surgery. So the medications indeed are an adjunct. A lot of our patients also believe, oh, it's Dr. Abby will give me this magic medication and voila, it'll be all perfect, but it is an adjunct. And we are looking at specialists for that 5 to 10% weight loss. So again, our patients will come to me, my patients will come to me wanting to lose 100 pounds, 120 pounds, and I respect that. I will tell them that there are 2 goals. My goal for my patient is 5 to 10%, because we all know as specialists that gives them huge improvement. But I respect patient goals too, and that way they don't feel like I am undermining what they are saying. But again, when the patient loses the first 5 to 10%, they might change their own goals at that point of time. So as specialists, we know that 5 to 10% weight loss helps our patient big time. The 5%, we'll already see patients losing improvement in their blood sugars, blood pressure, blood cholesterol levels, and the 10% is where we see the reversal of the NASH, and definitely patients have more energy and they just feel so good. The FDA principles, I'm sure we are all familiar with this. The FDA approved anti-obesity medications are indicated for patients with obesity, a BMI more than 30, or BMI more than 27, with presence of either type 2 diabetes, hypertension, and or hyperlipidemia. We are constantly monitoring our patients at least once a month, if not more, and we're looking for that 4 to 5% loss in body weight. And if that is not happening by the 3 to 4 month mark, we need to start evaluating and identifying what needs to change. Do we need to add a medication? Do we need to increase the dose? what's going on. So we're constantly, it's not that we give our patients the medications and then we're just waiting for the magic to happen. We're constantly monitoring the patients and seeing, do we need to change the nutrition plan, the activity plan, the medication plan, add medications, increase doses. I guess this is the most important slide today. Some of the medications are controlled substances, so please, you have to know the local and state policies with prescriptions on the medications, and of course, regarding your own malpractice insurance also. So let's jump right in. I will be discussing the FDA-approved anti-obesity medications for long-term use. I will discuss the FDA-approved medications for short-term use, and I will not discuss the off-label use medications. We live in a wonderful time period, a wonderful decade. In the 1960s, 1970s, the patients and physicians had access to most of the appetite suppressants. But since 2000, we have had so many new medications being approved by the FDA, so many more in the pipeline. So it's a very exciting time for us obesity medicine specialists, endocrinologists, working with the disease of obesity. In 2007, we had the approval of orlistat. 2012 was phentermine topiramate. 2014 gave us the naltrexone bupropion combination, as we got the GLP-1 liraglutide approved for weight management. And June of 2021, semaglutide got approved under the trade name Wegovy. And of course, for patients with genetic causes of obesity, with proven genetic causes of obesity, we have setmelanotide that was recently approved in 2020. So it's a very exciting time for us. Orlistat, I have zero experience with this medication besides the theoretical knowledge. So if any of you have used this medication, I'd be more than happy to listen to how patients have felt with the medication. Again, it is available as a 60 milligram capsule used to be used 3 times a day over the counter under the trade name Ally, and a prescription strength 120 milligrams 3 times a day with meals. It is a lipase inhibitor. So obviously with fat malabsorption comes the side effects of the diarrhea, oily, malabsorptive stools, which is the biggest deterrent for anyone to be using this medication. I'm sure it's got its good indications, but I have not heard any of us using this medication. So if any of you have the experience, I'm more than happy to listen about it. Okay. Definitely, we have to be very careful in patients with nephrolithiasis, because with the fat malabsorption, the calcium stays in the gut too, causing a hyperoxaluria and increasing the precipitation of the urinary oxalate stones. So in patients with nephrolithiasis, we have to be extremely careful with this medication. Are we still going okay with our slides? Perfect. Thanks, Dr. Earhart. All right. 2012, we have the approval for phentermine topiramate ER under the trade name Kisimia. Of course, we have the 2 components here, the phentermine, which is a sympathomimetic amine. It's been used since the 1960s, but the combination was approved in 2012. Phentermine, a sympathomimetic amine, it works in the hypothalamus, and it helps with appetite suppression. On the other hand, topiramate works on the GABAergic neurons and causes increased satiety. So the 2 medications put together are causing us decreased appetite, increased satiety, and helping our patients. We start the medication at a dose of 3.75/23 milligrams of the phentermine topiramate components respectively for the first 2 weeks, and then we increase the medication, the dose to 7.546 milligrams. And again, as I said earlier, we are constantly monitoring the patients. And by the 12-week, i.e. the 3-month mark, if the patient has not shown significant weight loss, about 3% weight loss, we have the ability to increase the dose again for a 2-week period to 11.2569 milligrams, and then to the full strength, 1592 milligrams. And again, you're looking for that 5% weight loss at the 12-week mark. Results with this medication. If you look at the studies with the responder rates, it was a 4x response rate. So we had 67% of the patients losing about 5% weight loss compared to 17% with the placebo. And we had 47% of the patients having a 10% weight loss compared to 7% of placebo. So the results with the trials showed excellent results. Definitely, we have to choose our patients correctly. With the topiramate, we know the side effects of the fetal toxicity, and hence I try to not give it either in the younger female patients, or you have to make sure that they're using 2 forms of contraception and check their urine monthly for the pregnancy test. And of course, with the side effects, with the phentermine, it's a sympathomimetic amine. So patients will get side effects like palpitations, insomnia initially, dry mouth, constipation, a little bit of hyperirritability, edginess. That's the phentermine as a sympathomimetic component. And the topiramate could cause some paresthesias, mental fogginess. I had one patient who actually was a CPA, and he declined to take this medication after a few weeks because he said it was interfering with his work. So patient selection with these medications is so crucial. Come 2014, we had the approval of naltrexone bupropion under the trade name Contrave, and liraglutide was approved in the same year. The naltrexone bupropion, it works in the hypothalamus and the mesolimbic dopamine reward system. Again, the two put together decrease your appetite, and it works on the hedonic response in our brain. It comes in an 8 milligram naltrexone and a 90 milligram bupropion dose, and it is escalated up over a 4-week period. So week 1, patients are taking 1 tablet every morning. Week 2, 1 tablet in the morning, 1 tablet at night. Week 3, 2 tablets in the morning, 1 tablet in the evening. Week 4, 2 tablets in the morning, 2 tablets in the evening, and that is the dose that we keep our patients on. Now, the important thing about this medication is that the bupropion and its metabolites inhibit the CYP2D6 inhibitor pathways. So we have to be very careful in a select number of patients, especially our elderly patients who are on multiple medications. We got to look for those drug interactions. Again, the results with these, we have the CORE1 and the CORE-B one of the behavior modification studies. And as you can see in the clinically significant weight loss results, when 42% of the patients had 55% weight loss compared to 17% with the placebo, so that's 3 times. And 21% of the patients had 10% weight loss compared to 7%. So you're seeing excellent results with the medications. But again, patient selection is so crucial. Because if you have patients who are on opioids for pain syndrome, you cannot give them the naltrexone. Bupropion is contraindicated in patients with a history of seizure disorder and eating disorders. So you have the patient selection is crucial with these medications. There is a boxed warning for Contrave. It does increase the suicidal ideation in children, adolescents, and young adults. So again, it is contraindicated in a select number of patients. Some of the adverse reactions would be nausea, constipation, headache, vomiting, but more crucial would be the worsening of the depression and the suicidal ideation and seizures. So again, I'm going to recap. Bupropion is contraindicated in patients with a history of seizure disorder and eating disorders. So patients have to be screened very carefully. Here we are in the decade of the GLP-1 agonists. All of us are so excited about it. Our patients are so excited about it. Unfortunately, with the shortage, the national crisis, we are all tied. GLP-1 is an incretin produced in the small intestine, and it's crucial. It enhances the role of, in response to carbohydrates, it enhances insulin. It suppresses glucagon, so it prevents the hepatic gluconeogenesis. It does slow the motility of the gut, and it works in the hypothalamus, also causing decreased hunger, increased satiety. So liraglutide and semaglutide are already approved for obesity management. We'll talk about the doses in a few minutes, but the liraglutide is a 3 milligram subcutaneous daily injection, and the semaglutide's highest dose would be a 2.4 milligrams. Liraglutide has a 97% homology with our GLP-1 and semaglutide at 94%, so it's pretty close. The biggest contraindications for our GLP-1s are our history of medullary thyroid carcinoma and the MEN type 2 syndrome. Of course, all these medications are contraindicated in pregnancy. Again, with the GLP-1 agonists, the biggest side effects you're looking at are nausea and diarrhea. You want to make sure that the patients are keeping themselves hydrated, and you want to prevent that acute kidney injury. And you're also monitoring the patients for abdominal pain, nausea, vomiting, pancreatitis, and with liraglutide, you're looking at cholestasis, cholelithiasis. So here we go with liraglutide. It was approved in 2014 for obesity management. It had been in the market prior for diabetes. It is a titration over a 5-week period. So week 1, we're starting at 0.6 milligrams subcutaneously. It's a daily injection for 7 days. Week 2, 1.2 milligrams subcutaneously daily for 7 days. So it's a 0.6 milligram escalation every week. Week 3 is 1.8 milligrams. Week 4, 2.4, and week 5, 3 milligrams on a daily basis. Again, it's a GLP-1 with 97% similarity to our endogenous GLP. We had the results with the SCALE trial, and the results have been exceptional. We are seeing 62% of our patients with 5% weight loss and 34% with 10% weight loss. So with the GLP-1 analogs, we are beginning to see responses equivalent of surgical weight loss. And I think that's why a lot of us are so excited about using these medications for our patients. So again, out here in the middle box is where we see the results. 5% weight loss, 27% in the placebo patients, but 63% patients had 5% weight loss, 33% with 10%, and 14% of the patients had more than 15% weight loss. So you're getting close to the surgical weight loss over here. Semaglutide, under the trade name Wegovy, was approved in June of 2021. It had been used as Ozempic for a long time for diabetic patients. The biggest positive of this medication is it is a once-a-week injection. Again, it's titrated up every 4 weeks. So you start off at 0.25 milligrams subcutaneously once a week, 1 to 4. Month 2, it titrates up to 0.5 milligrams. Month 3 would be 1 milligram subcutaneously Q weekly. Month 4, 1.7 milligrams, and then the 2.4 milligrams. And that's where you maintain our patients. Again, it is 94% similar to our endogenous GLP-1 and an excellent results. We had the STEP trials with the semaglutide. And we are seeing, again, if you look at the box down here, you're seeing 84% of patients having a 5% weight loss. But look at this, we have 53% of patients having a 15% weight loss. So we are getting to the 15 to 18% mark. And mind you, bariatric surgical patients are at 20 to 25%. And I'm not, you didn't hear this from me, but that's what we're seeing the results with tirzepatide at this point of time. So again, this is the middle box, which shows that patients, about 18% of them are showing, with the highest dose of the semaglutide at 2.4 milligrams once a week, we are seeing about 18% weight loss. Again, we are monitoring the patients for abdominal pain, nausea, vomiting, the pancreatitis-like picture, and making sure that there's no evidence of acute kidney injury. Any questions so far? Just keep going.
There was just one question. For these weight loss medications, have any of them been studied for like 5 years plus for long-term weight loss?
Well, with the GLP-1s, we are going to start seeing that shortly because, again, they have been studied since the early 2010s. But yes, with the topiramate and the Contrave, we have good results. They have been used for more than a decade, and we have excellent results. The phentermine, actually, the studies among all these medications, I would say that phentermine topiramate has really shown excellent results. Of course, now we have the GLP-1s coming in the market to compete with it. But it has been approved for children beyond the 6-year mark, and you cannot prescribe this medication until we have proven genetic defects in the POMC, PCSK1, or the leptin receptor deficiency. So I've given you the dosages over here. The children 6 to 11 years of age, you start the medication at 1 milligram subcutaneously daily for 2 weeks, titrating it up to 2 milligrams. And in children more than 12 years and adults, it's 2 milligrams subcutaneously once a day for 2 weeks, and you titrate it up to 3 milligrams. And again, I'm sure working at an academic center, you probably have more experience with this medication than I do. All right, so we are done with the FDA approved medications for long-term use. The ones for the short-term use have been available since the 1960s, 1970s. We're going to start with phentermine, which we already discussed briefly previously. And then the others, the phendimetrazine, diethylpropion, and the benzphentamine are pretty much weaker sympathomimetic agents similar to the phentermine. Phentermine it's a sympathomimetic amine, again, working in the hypothalamus, causing decreased appetite. It's available as 15 milligram, 30 milligram capsules, and the 37.5 milligram is a scored tablet, so patients can break that if needed. At 8 milligrams, it's actually called Lomira, but I have a lot of patients who benefit from that medication too. Lower dose, less side effects. Again, because of the sympathomimetic amine, the side effects of this medication are a little bit of hyperirritability, insomnia, palpitations, transient increase in blood pressure. So we have to be careful in patients who have uncontrolled hypertension. Of course, it causes dry mouth and constipation too. The rates that they've shown are for about 50% of the patients have a 5% weight loss, similar to that with 10%. But again, in our program, we see significant positives of this medication. Diethylpropion is wonderful in patients who have the side effects of the phentermine. It is a weaker sympathomimetic amine. So if you've used phentermine, you know how to use the diethylpropion also. It is available as 25 milligrams or a 75 milligram extended release formulation, but pretty much similar to the phentermine. Phendimetrazine is a controlled substance 3. It is available in 35 milligram dosing and 105 milligram extended release. The 35 milligram dosing, I think many of us will use it in combination with phentermine occasionally if needed. So to break, you give the phentermine in the morning, and if their patients are still struggling with evening hunger, we can add a little bit of phentermine, the phendimetrazine at maybe 2 o'clock in the afternoon. Again, it has a shorter half-life, so the patients benefit from it, but it is overall a weaker sympathomimetic amine than phentermine. Phentermine is controlled substance 4, phendimetrazine is controlled substance 3. And the same thing with the benzphentamine. So if you know how to use the phentermine, the rest of them are all pretty much alike. So the sympathomimetics, some people say that it should be avoided in patients with uncontrolled hypertension. Well, when you put your patients on a good nutrition plan, a good physical activity plan, and once they start losing weight, their blood pressures do come down. So we're actually by then taking down and tapering down their blood pressure medications. So I'm comfortable in making sure that the patient's blood pressure, of course, I'm not talking 180 over 110 over here, but if the patient has 140 to 150 over 80 to 90 or 90 to 100, I'm comfortable in starting them on this medication, making sure that they have been compliant with their antihypertensive regimen, discussing a low salt diet with them, because I would say the benefits outweigh the risks at that point of time. But definitely it is contraindicated in patients with closed angle glaucoma, severe hypothyroidism, and none of these medications are approved for patients with pregnant mothers and nursing mothers. Although if a patient is on phentermine and does get pregnant, we can have them stop the medication. We are not as nervous as we were with the topiramate. Again, I'm going to just skip through these slides, but many of us use the metformin and topiramate as an off-label use, along with zonisamide, bupropion, the SGLT2 inhibitors. Then you have the GLP-1s, which are not FDA approved specifically for obesity, and then the amylin agonists. But since we are talking about the FDA approved medications, we are going to whiz by through this. I wanted to spend a minute talking about special populations because this will direct us in our management. So if we see a patient with depression and obesity, or a patient with smoking cessation, we might pick bupropion as a first choice. We know that lisdexamfetamine is definitely FDA approved for patients with binge eating disorders. If you've identified a patient with night eating syndrome, they would benefit from sertraline, citalopram, escitalopram. Diabetic patients, of course, at this point of time, are metformin and GLP-1 agonists would be choice 1 and choice 2, or reverse. And patients would get the spironolactone for premenstrual carbohydrate craving. So these are just combinations that you could use with other medications. In the pediatric population, again, I'm going to skip to the second half of the slide with the FDA approved medications. So orlistat and liraglutide have been approved for children beyond 12 years of age, and phentermine has been approved for adolescents over the age of 16. If we talk of the other end of the spectrum with a geriatric population, Unfortunately, none of the older medications, the sympathomimetics, had been gone to trials where we had the geriatric population. But again, I have used the medication for people 65 and 70 years of age, and they are relatively safe. Again, in the elderly, we're definitely looking at the kidney dysfunction or kidney function and the drug interaction, especially since we talked about the bupropion. So just be more mindful. All right. None of the medications are approved for pregnant women. And of course, besides topiramate with the fetal malformations, any of the other medications should be stopped prior. With the semaglutide, the indication is to stop it 2 months prior to contraception. And these are more of the relative contraindications, again, as you're choosing your anti-obesity medications for your patients. So if you have a patient with brain fog or depression, or like I said, my CPA who couldn't afford to be foggy in his head, you don't want to give them the topiramate or the zonisamide. We've talked about the uncontrolled hypertension or the hypothyroidism. And for those, the sympathomimetic amines would be contraindicated or relatively contraindicated. So you'll be used caution with phentermine topiramate, phentermine, or the diethylpropion. In patients with glaucoma, definitely you want to, again, avoid the sympathomimetics, the glycemia, phentermine, diethylpropion, and the zonisamide. We've talked about topiramate actually causes the metabolic acidosis, and hence it is an increased chances of renal stones. And with orlistat, you get the hyperoxaluria and the oxalate stones. So you want to prevent those two in patients with a known history of nephrolithiasis. Again, topiramate causes paresthesia. So in the patient with having paresthesias, neuropathy secondary to diabetes, be cautious with topiramate. Bupropion is definitely contraindicated in patients with seizures and eating disorders. And of course, with orlistat, you have the fat malabsorption. So you're looking at the vitamin A, D, E, and K as your fat-soluble vitamins. So in patients with vitamin D deficiency, these are all relative contraindications. That was a slide. I think this is one of the crucial slides when you're trying to figure out what medications to use or avoid. These are just the references, and that brings us to the end of our talk.
Thank you so much for that great information. I think the last slide sort of summarized like the side effects, but what I often tell people, especially with like a topiramate, which, acidosis, increasing the risk for gout, numbness and tingling, memory fog, and what I tell people is, remember, a lot of people are on it for like seizure prophylaxis at 150, milligrams a day. And that acidosis doesn't typically occur until it's greater than 100. And similarly, at doses we might be using 25 to 50, you may not see any side effects. So tell us a little bit, because I think it's the side effects that sometimes limit it, but the more I practice, the less I'm seeing it in my clinical practice. So tell me what your experience has been. So
actually, I do use phentermine in my office, again, at the lower doses, the 25 and 50 milligrams. I will caution my patient. I will monitor them closely, especially in a patient with nephrolithiasis. I'll talk about increased hydration. So you're right. Sometimes the theoretical aspect and the practical aspect are two sides of a coin, but definitely I use them in a lot of my patients. Just monitor the patients more carefully. I think a lot of primary care physicians, unfortunately, prescribe anti-obesity medications, but they don't have the close follow-up. And that's where I think we face the warning signals for them.
And I think that's a great point. Even with our problems with scheduling, anyone I'm putting on a medication to support them for weight loss, I try to see every 4 to 6 weeks. And sometimes that is challenging, definitely. Any other pearls specifically for binge eating? Like, tell us a little bit about your experience, what medications you feel like has helped the best for binge eating.
So again, all right. So the most important thing is, I'm not familiar with the names over here, but cognitive behavioral therapy is huge in those patients. So that is, I would say, number one, but the lisdexamfetamine and the SSRIs definitely help. Again, I do not work at an academic center anymore, so I don't have much experience with these patients. I used to see a lot of them in the past, but definitely the CBT helps big time. And that's why it's important to work in an interdisciplinary setting where you have, the access to a psychiatrist, psychotherapist, a nutritionist, an exercise physiologist.
And then, what's come up in so many of our discussions is just the cyclical weight loss and weight gain. Tell us some trends or some things that you do with your patients to help with the ups and downs of their weight.
So I think a lot of it is also expectations on the part of the patient. Right in the first appointment, I will tell my patients that weight loss is a two-part journey. Part one or part A is to lose the weight, but part two or part B is the more important: weight maintenance and prevention of weight regain. So patients do great when you're following up with them acutely one-on-one to help them lose the weight. For the weight maintenance and prevention of weight regain, I tell my patients, I'm going to be seeing you every 2 to 3 months for the rest of your life. Just like a patient, like diabetes is a chronic disease, and a diabetic follows up with their primary care patient or endocrinologist every 3 months. The same thing with hypertension. They follow up with their PCP and or cardiologist every 3 months. So I tell my patients that I am going to be following up with you every 2 to 3 months for the rest of your life. Because at the 2 to 3 month mark is when the weight plateau or the weight regain could start. And the sooner we catch it and the sooner we fix it, the sooner we identify what needs to change, the better it is for the patient. It is frustrating for the patients to lose 10, 15, 20% of their weight and then regain it all. It is frustrating and it's hard work to get it back down. So I think frequent follow-ups is so crucial.
Great points. And there was a question in the chat that said, when you initiate a medication, how soon do you see the patient back again?
So I like to see my patients every week for the first 2 to 4 weeks. Then I'll see them every 2 weeks and then once a month thereafter. But a lot depends on how comfortable the patients are also. But you can see patients every 2 to 4 weeks if there's a level of comfort between your patient and you. So many times patients have done this so many times before. Often patients will come to your office saying, oh, I've taken phentermine before and I don't want to take it again. But the problem with that is in the past, they've probably gotten it from not an obesity medicine specialist. So they've not followed a nutrition plan. They don't have a physical activity plan in place. So I think reintroducing the medication, if they are agreeable, and close follow-ups really helps those patients.
Great point. And there's a question in the chat that Laura answered about the low risk for phentermine withdrawal. Do you prescribe it, in people who have a history of addiction at all, if it's well in control? Tell us your experience with that. Or is it a medication you avoid?
So I think the thing with the addiction to phentermine, it's been proven that patients do not get addicted to it. The more you communicate with your patients, the more you follow up with them, the more you explain to them that this medication is not for long-term weight loss. We will give it to you for a short duration. And again, in some states, it can be prescribed only for 3 months, but I have used it for patients for 6 to 9 months. And again, the addiction potential does not come as long as the patient knows that it is used as an adjunct to the nutritional plan, the physical therapy plan, and the behavior modification. So I really think the behavior modification piece is one of the big crucial aspects of this journey. And with that, then the addiction potential does not come.
And do you ever prescribe phentermine with other stimulants, like for ADHD medications?
I choose not to. I don't know what your experience is. If anyone in this group does.
I would not.
I have occasionally in my younger, healthier population. I think you're always weighing the risk of, the benefit to the heart, to the blood pressure and the mental state with the weight loss, with that risk of the insomnia, the anxiety, etc. So it's a select few that I have, but I have used it.
Again, patient selection is so crucial. It is so crucial. I have some patients who are actually on 0 or 1 medication, and then I have some patients who are on 4 medications. So again, it's all about the patient selection.
So there was a question on what to do if patients doesn't follow up regularly. I will point out that phentermine can be stopped even at a high dose abruptly, but there's a few medications. So bupropion at high doses can lower the seizure threshold if you stop it abruptly, and then also topiramate. So
Correct.
what I would do in that case is I might do a month supply where I recommend they take a lower dose every other month, but not fill anything else. And that if they don't come back. And I do put in my counseling notes that these once I get to the higher doses, you can't abruptly stop them. So coming is important.
Absolutely.
Any other experience that you do or anything else you add to that? Because that is a challenging thing, definitely.
It is. And again, it's all about patient communication and keeping the patient engaged. Sometimes if the patients cannot come to you for whatever reason, because of distance or time factor, you can do your telemedicine appointments also, but keeping the patient engaged, informed, and educated is very crucial to prevent disasters.
And Laura, a quick question for you. Do all of you, and I'm going to ask the same thing as well to our speaker, do you always encourage or have them do mental health and nutrition component along with anti-obesity medications? Or is it sometimes you're just doing the medications? Or is it always a multidisciplinary approach?
No, it's generally always when the patient leaves the office, they may not incorporate all the pieces, but yeah, every visit I talk about sleep, mental health, we go over nutrition, exercise, and we also talk about the medication. So it's not just purely the medication.
I agree, because again, the more, even patients believe or the belief still out there is, oh, I just need to exercise more and eat better. But the more you educate the patient on how stress is playing in the disease of obesity, how lack of sleep is playing in the disease of obesity, the more understanding they have, the more they can, you're enabling them to help themselves to a certain degree. And of course, CBT is huge in the behavioral management aspect of the disease.
Great point there. And I think, the shared partnership is something that comes up all the time in every single one of our discussions. And so we're going to go ahead at this point. And Cara, I see you made it from your patient. So go ahead and introduce yourself a little bit and we'll go ahead and start the case. Thanks so much for being here today.
Okay, yeah, I'm Kara. I work in primary care at UW Belltown. So this is a 37-year-old female patient who has a pretty significant psychiatric medical history. So sorry, my computer just logged me out. Okay, can you still hear me?
Yes, we can.
Yep, okay, oh, there we go. All right. Okay. So she had some traumatic experiences, I think, with abuse from family members in childhood, and then unfortunately was in an abusive relationship as an adult as well with her ex-partner. And so from that, she's had a lot of PTSD and anxiety and treatment-resistant depression. She's tried a lot of things for her depression and anxiety and PTSD, but more recently has actually stabilized. So she's being seen by an outside psychiatrist, getting esketamine nasal spray treatments every month or so. And so she actually is feeling like as good as she has in a long time. And so now is kind of looking to address some of the other parts of her life. I guess other important past medical history, I don't know if you can scroll back up just to the other past medical history there. So she suffered a TBI in 2014 and has had ongoing fatigue and brain fog and headaches, and actually had pretty persistent migraines that started after that. And so she's actually on disability for those symptoms. Otherwise, she also does smoke. So she smokes about half a pack a day. And so she came to me, the appointment that I had with her was she was interested in options and medications to help with weight loss. So she currently has a BMI of about 41. So she has tried a few medications in the past. Let's see. Well, I guess I'll go over her current medication. So you can see she's on Buspar, venlafaxine, hydroxyzine orally, and then this esketamine nasal spray. She's also on methylphenidate daily for indication I could see from the chart was for fatigue and concentration. I don't know if she has an official ADHD or ADD diagnosis. She is Ajovy for migraine prevention and a few other medications that aren't super pertinent. She's on spironolactone for acne and cyclobenzaprine for headaches and rizatriptan PRN for migraines and some vitamins. So in the past, she she did actually try metformin in the past for help with weight loss. It sounds like it didn't make much of a difference. She used it for over 1.5 years, and she also didn't like that it changed her body odor. And then just from prior discussions with her PCP, she is currently on a stimulant for fatigue and concentration. So phentermine wasn't thought to be a great option for her. And then I think she actually had tried topiramate at one time for migraines, but it also thought that topiramate wouldn't be a great option for her just because of her ongoing brain fog that she's still dealing with. Let's see. What else? Yeah, so yeah, we talked about right now she's on disability. She's actually trying to go back and take some classes in community college right now. She's single, doesn't use alcohol. Fortunately, she doesn't have a lot of comorbidities from the obesity, so she's not on treatment. She doesn't have hypertension. She doesn't have prediabetes, so that's great. Yeah, all her labs are basically normal blood pressure. Her cholesterol's not too bad. And she has had some workup in the past year, and I think prior to that too, just for the weight gain to rule out like other causes, but she's had normal TSH and a normal cortisol level. She actually did meet with a nutritionist at our clinic in 2021 twice, and she was referred to the UW weight loss clinic over the summer. She ended up not scheduling, and I actually didn't ask her why she didn't schedule, but she didn't follow up with that referral. And yeah, she does have quite a bit of just some barriers, socioeconomic and just overall life instability barriers. I think things have stabilized a lot. So she previously did go through a period of homelessness. She's still on a pretty limited income, and so significant out-of-pocket costs for medications would be pretty cost prohibitive for her. She still gets some food from a food pantry, so doesn't have like total control over her diet. So, and let's see here. And then I just included some information from like prior nutrition notes. So when I met with her, I didn't do like a full dietary recall, but did have some information from like prior chart notes. So sounds like a lot of her weight gain occurred after her TBI, but it's fluctuated a little bit over the years. And I think if you scroll down, there's a little bit more information about her dietary habits. So she feels like and it seems like for the most part, she, makes pretty good dietary choices. I think a lot of her frustration is she feels like she's doing everything right and still is not seeing results, is still continuing to gain weight or not lose weight. So a little information there about her diet, but she does eat a lot of fruits and yogurt and nuts, but doesn't eat a lot of, super processed foods or soda or juice, or really super obvious like targets that we could target for dietary changes. And I don't know if I wrote it in there in terms of physical activity. So she does yoga 3 times a week, and she generally walks twice a week. I didn't ask and don't have specific information about like how long is she walking or how far, but she tries to do something most days.
So first of all, I apologize if I'm not seeing this, but how did the traumatic brain injury occur, and what part of her brain was affected?
Yeah, I don't have a ton of information about that. She fell down a flight of stairs, and it was before she had care at UW, but I don't think she was hospitalized. I think she did have loss of consciousness, and that's about the most information I have. Sorry.
Okay. And how does she spend her time?
Yeah, good question. She is taking classes at community college, and yeah, I don't have a lot of other information about how she spends her time.
Okay. And what are her goals for weight loss?
Yeah, we didn't talk about like a specific like weight target. I think her goal, she feels like she's continuing to gain weight. And so I think she'd like to stop gaining and start losing and get to a healthier weight. But yeah, we didn't talk about a specific target.
Allison, great clarifying questions there. It actually made me think of one other question. What is her current support at home or among friends and family?
Yeah, she does have a few close friends. She does have a new partner that she doesn't live with but sees, and so I think that's her main support. She, I think, doesn't have a great relationship with a lot of her family due to some of that prior trauma and bad relationships in the past.
And if there's no further clarifying questions, take it away, Laura. Great questions, guys.
So thanks, Kara, Nicole, and Dr. Abby, of course, for that excellent talk. So this is a really great case to discuss today because I think it encompasses so many of the challenges that we see in obesity medicine. But we have a 37-year-old female with class 3 obesity. She's got a BMI of 41, and it's complicated by her depression, anxiety, PTSD. She's a smoker. She's got these migraines, this brain injury, which has left her with fatigue, brain fog, and headaches. And the questions that Kara had listed that we wanted to address today, specifically, are there any medication recommendations for weight loss when patients do have coexisting psychiatric diagnoses? And one of the questions was, are there any tips for getting them covered for weight loss? And she also had a question about, what should we tell our patients when they feel like they're doing everything right, but still not losing weight? So I just added her medications there again. And so again, recapping just her individual characteristics. genetics. So we've got class 3 obesity. Her A1C was in the normal range, so there's no prediabetes. She's on disability for her migraines, but it sounds like she's going back to school or retraining. She is smoking currently. She does have some insurance, Aetna, Medicare Advantage. She did have an elevation of her triglycerides on her last blood work. Blood pressure was a little bit elevated, I guess diastolic, and she is on spironolactone, but it's for her acne, not for hypertension. She has had a hysterectomy in the past, but she still has her ovaries. We know she didn't tolerate metformin. We've obviously got the brain injury and this chronic fatigue in which she's on the methylphenidate for. And again, her treatment-resistant depression, anxiety, PTSD, and she's seeing an outside psychiatrist, and these are her current treatments. So the first thing I think, with this case that we want to address, and this is the first thing that I would say I address in my obesity medicine practice is, mental health really is going to be paramount to optimize before we start getting into, it'll tie in with her intensive weight loss. So we did get some clarifying. We asked Kara this past week just to get some more information, and her PTSD was apparently due to this childhood trauma from parents, and also she had an abusive ex-partner, and then the brain injury was from a fall. And she's been doing well, which is great for her depression, mood, anxiety, and she really doesn't want to make any changes to those medicines at this point. No known night eating and no panic attacks. I'm going to pass it on again so we can discuss a little further on the mental health topic, but I'll pass it on to my psychiatry colleague.
Hi, Laura. Thank you. Yeah, so I know we're really pressed for time here. Look, this is a very complex individual. The good news is that her behavioral health issues seem to be stable, but that doesn't mean that there aren't behavioral health issues to address. Meaning, we think of behavioral health for diagnostic purposes and coding purposes, but there's behavioral health and then there's health behavior, right? We've heard that's the paramount thing that we have to address. And so in my mind, I would really focus on day-to-day. And while we don't know that she has, we really might want to ask, does she eat 25% or more of her daily intake after supper time? So there may be some night eating. We have some links here from articles from work in patients with diabetes. In our clinic, 10% of them had night eating syndrome. Or 9.5, or night eating issues, perhaps not meeting criteria. And now it's part of DSM-5. And what that means is that you're eating 25% or more of your daily intake at night. And it's often in response to common things like loneliness, feeling hurt, injustice, things like that. There's a video that I actually found from about 10 years ago that I did an interview after we published that paper. So you can take a look at that to understand what night eating is. And at that time, it wasn't in the DSM, it is now. When we hear about PTSD, the question, the devil's in the details. Do they actually have PTSD symptoms now? And if so, are they being addressed? And I'm being pushed along here. So I'll just say, same thing with ADHD. We're hearing that we can't try phentermine because she's on a stimulant. Well, why is she on a stimulant? We're hearing because she has fatigue. Well, is that an appropriate use of a stimulant? And so I would really do, like, for example, the DIVA-5 is a great way to help us clinically understand, did she actually have ADHD or AD as a child? And does she actually have a diagnosis of ADD as an adult? Perhaps she doesn't. And more than likely, most adults that didn't have it as a child often have non-specific inattention symptoms because of depression and anxiety that is not adequately treated. I would just say, Allison asked about the TBI issue as well. We're only hearing about brain fog and fatigue, chronic fatigue. I wonder, again, it'd be good to know about imaging, getting a neuroconsult, neuropsych testing, because we're hearing that she can't exercise because of this disability. And it would be good to sort of help her accept, her explanatory model of what is this disability. Can we get her to exercise more, for example, or is there even, does this TBI affect her ability to organize her chronic conditions as well? So clarity, devil in the details. I'll stop there because I know we're pressed for time.
So I did have here just some of her barriers that Kara illustrated and the exercise routine that she's been doing, and just a little bit about her weight history. And it seems like the hysterectomy was kind of a changing moment, but also after her brain injury, the weight, she mentioned that she stopped doing her active job and the weight started to creep up from there as well. And she does make a note that maybe medication has played a role too. So weight gain with medication medication changes. But her usual weight, it sounds like, was about 150, and now she's at the 239 point. Kara did a good job just kind of summarizing this, but her barriers for nutrition, the brain fog, and just the mental energy to prepare her food is difficult. But it looks good that she's, eating regular meals still. She's not skipping meals, but again, just illustrating those barriers there too. So in my family medicine brain and obesity medicine specialist brain, the first thing I think about when a patient is seeing me, again, in addition to the mental health, which I think is paramount, I also kind of look at, are there medications that I'm prescribing or that the patient is taking that could be causing weight gain? And this is just a list of some of the more common medications that may do this. Her venlafaxine may potentially be an issue, but otherwise, looking at her med list, I didn't see anything else that, was kind of obvious. But when you're seeing your patients, you definitely want to be looking at that also as a kind of secondary measure. So again, my kind of moving on from my initial thoughts. So is she taking any obesogenic or weight promoting medications? Maybe the venlafaxine. The other thing that I think about when I see a patient for a consult for obesity, have we screened for all of the possible comorbidities that we may be dealing with? And obesity, we'll talk a little bit more about that, but obesity is a high risk for cancer, and I would want to make sure that she's got all her preventative care going. But are there other things that we haven't checked for? Also, kind of along the same lines as our, discussion about her mental health, disordered eating is very common in obesity, and especially binge eating, night eating, as has already been discussed. And in my practice, we do screen for it, and I do, we have a team in our clinic, but they're not specialized specifically. And I feel like when I've tried to treat patients just, with, a touch of, I guess, CBT, they really don't do as well as when they get cognitive behavioral therapy. So I think it's really important to see, is there just like an eating disorder, and should this patient see a specialist first for that? And also the goal, we've kind of talked a little bit about what her weight loss goal is. So looking at comorbidities, I mentioned cancer, these patients are very high risk. Our adipose cell does secrete factors which increase the risk of cancer. But sleep apnea, very common. So if this patient hasn't had a stopping, I think that should be essential. And certainly that could tie into her brain fog and things. So, and as Dr. Abby mentioned, sleep is so critical during weight loss, and it can interfere with the circadian rhythm of some of our important hormones that regulate weight. So I think for this patient, we probably should screen for that. But also, I know her brain fog seems to be the main barrier for her, maybe for her exercise, but I'd also ask her about, joints and things, like maybe she needs to have some physical therapy to help with her movement, reflux and things. Potentially, metabolic surgery could be an option even to treat reflux. So that would be another thing to ask about. Vitamin D deficiency, also very common in obesity. So I think that should be definitely assessed. And some people do feel a huge difference when they start vitamin D. A lot of people don't, but some people feel like it does. They feel more energy and things. But I'd also kind of ask about, make sure we have potentially for this patient, because she's got pretty, her triglycerides are elevated, no diabetes, but maybe doing an fasting insulin level could be another piece that we could add to further assess that. But also thinking about some of the skin, but also neurologic, could these headaches be related also to something like pseudotumor cerebri? Just a note here, I won't go through this in detail, but in our clinic, we use the BED7 questionnaire, and it's a questionnaire that basically goes through the DSM criteria for binge eating. And I definitely think that this is something that, when you're seeing your patients for obesity, you may want to go through. And again, I think first and foremost, they should probably be referred for intensive behavioral or cognitive behavioral therapy, because that is the primary treatment. But like Dr. Abby mentioned, there are some other medications like Vyvanse that we could use as well in addition to that. For her goal, I think Dr. Abby also illustrated this quite nice in her lecture, but for her, we probably want to aim for about 10% weight loss. We know that's going to have a reduction risk for diabetes, and it should help improve her triglycerides. Her blood pressure, again, was a little bit elevated. So I definitely would say if this person doesn't, mental health stable, and we're not, dealing with binge eating or other disordered eating, I think 10% weight loss would be a great goal. So about 24 pounds. So our first question, medication recommendations for patients who have coexisting psychiatric diagnoses. So it's great we have an experienced panel, Dr. Abby, and we've got our psychiatrist, but these are just some of my doctor and obesity specialist. So I probably wouldn't go with a stimulant for her at all with her, anxiety, and also she's smoking as well. So I think phentermine and Qsymia, I would definitely take off the table kind of right away. Even if she weren't on a stimulant, I would just worry that could increase her anxiety. Contrave, I think, could be an option. To phentermine, actually, Contrave is more notorious actually for raising blood pressure and heart rate. So, with her kind of bordering even on spironolactone, I guess I might, worry about her heart rate. And in my family medicine experience, I wouldn't combine venlafaxine and bupropion. I know they can, but I think it'd be interesting to hear from my psychiatry colleague or even Dr. Abby what they think about combining it. But yeah, maybe it could help her quit smoking, but I think that would be an option. Do you have any thoughts?
Yeah, I mean, we often augment any SSRI or SNRI with bupropion, again, just during all the contraindications, but assuming she doesn't have an eating disorder, which you'd want to screen for, and or a history of seizures, and doesn't have, I will say, hypoglycemic episodes, which I don't think she does, but that's another thing that I've learned from my 20 years in working in the diabetes care center, is that's a risk too. Then, I think cautiously augmenting with bupropion, we do it all the time with, but of course that's an issue for the psychiatrist, who's now also treating her with ketamine and buspirone and stimulants, which, it's quite a soup of medication. So I would really be careful.
What dose I know you said that she did not tolerate the metformin. Do you remember what dose she was started on? Because I've seen that sometimes if you start metformin at a higher dose, patients will complain of the abdominal symptoms. But if there's no pressing reason, you can start them at like 250 milligrams or 500 milligrams once a day, and they tolerate that much better. So I was just curious what dose she was started on.
Yeah, I don't have the information off the top of my head. I know it was a while ago. So yeah, I don't, but that would be good to know.
Yeah. And again, this bupropion and venlafaxine, definitely, it's a good combination, but I would leave it to the psychiatrist. I would not be confident in doing it myself.
That's how I would feel as well. But yeah, I think it's definitely a thought against quitting smoking as well. I think we could think about using naltrexone alone if she's not on opioids. It sounds like she already did try topiramate, so that might not be, or I guess maybe the PCP thought it might worsen the brain fog, but I think those could be options, but just alone, I don't know how necessarily robust the weight loss would be by itself, but I think they could be options. Another idea, which may not work for this patient because she's got some financial difficulties, is this Plenity, and it's not actually a medication, it's more of a device, but it makes patients feel full. But for patients with mental health issues, I think that could be a great option because some of these, as you can see, may impact her other mental health medications, but an option. The other thing, I guess, just kind of summarize, I think for this patient, I probably, with her Aetna insurance, and she does have some sign or some features of metabolic syndrome, I think we could potentially get her on liraglutide or Victoza. So I think that's probably what I would lean towards because it's not going to impact her other comorbidities. And then just a comment about the GLP medications, as you probably everyone knows on the panel and in the group, they're very costly. And now we've got these shortages going on. So there's many patients who are just not able to kind of continue, but also for obesity specifically, this patient may not even have benefits. So she may not even be able to get the GLP medications specifically for obesity. But again, for her, I think I would think about liraglutide as an option and just document and make sure that you put that she did try metformin first. But some patients or some insurances won't even cover liraglutide unless they have type 2 diabetes. But I think with Aetna Medicare, she may be okay. And this is just a slide that Nicole had added. Do you have any specific comments about this, Nicole?
Just, we are talking about combinations of medications, and I think we were thinking about her stimulant use and phentermine topiramate, but in my review, the venlafaxine with the phentermine topiramate seemed to be potentially also an issue, increased risk of like psychosis and episode, so several case reports of that. And it was something in my review, this is, if you don't know, look up, right? And so I learned something by, looking at her as an individual. Go ahead, Paul.
I'll just comment. I mean, again, adding a stimulant to an SSRI and then adding phentermine, you just have to be very careful. And so it's no wonder that there's potential psychosis. You have to be very careful with these meds. And again, this is again where I go back and go, does this person have ADHD? Why is she on a stimulant? Because it's probably a barrier to appropriately addressing her weight issues, because you can't start these things. I would also really consider the interactions with meds, whether it's the bupropion, adding a stimulant, and all these things. So I think what would be really helpful in this case would be to have good coordination, communication with a psychiatrist or whoever is prescribing these meds. That would be the best thing. And stepping back and going, why is she on these 5 meds? Does she really need to be on these 5? Does she really have brain fog because of her TBI? Because again, I keep hearing that is a reason that she's not able to do all these things for her weight loss. And so a neuropsych and maybe neurological testing at some point would be appropriate.
Great, thanks so much. So our next case question was, are there tips? Like, how can we get these medications? And outside of, for the actually FDA approved obesity treatments, we do have, I'm not going to go over these because we've talked about them in our other sessions, but there are several assistance programs out there. But the problem is the patient still has to have the benefits, which can be a barrier. So these may not be all that helpful, but like I mentioned in the earlier slide, the fact that she does have some signs of metabolic syndrome and insulin resistance, if she's tried metformin, we can usually get her on a GLP, but liraglutide, we might have a better chance of getting her on to start. Our next question is, what lifestyle advice do we give when patients feel like they're doing everything right and still not losing weight? And I think, guess from here, I'm going to pass the torch on to Nicole, because she definitely has some really great insights as an endocrinologist and, looking at the other hormone aspects.
So when I saw this case, right, I saw TBI and I saw hysterectomy, right? And so my first thought was, we want to make sure there isn't other comorbidities going on. And I think, more and more as an endocrinologist, what we've seen is that TBI can cause pituitary dysfunction. And there was a good initial evaluation of her hormones, including a cortisol and a TSH. But remember, if it's a central process, the thyroid stimulating hormone can look inappropriately normal, okay? And so really, maybe she needs a free T4. And then the other thing is, around the hysterectomy time is when she started to have the fatigue. Now, I did clarify with Cara, and she did say she does still have her ovaries, but I also was starting to think with the TBI, is this someone who potentially could have a central hypogonadism, and or is there something else that maybe she went through premature ovarian failure or premature menopause, right? And so, I do think she might benefit from a little bit more of a hormonal evaluation with that free T4 and then an estradiol level as an end product. And again, we'll take the LH and FSH with a grain of salt. If they're elevated, that helps us say something. If they're normal, but the estradiol level is low, it could be from a central process. And so, I often hear mental fog around my menopausal women, and I do want to point this out because what ended up happening and what we saw was that the Women's Health Initiative came out, and the average age of the people that were on hormone replacement were 65 or older, okay? And so what happened is, because there was this increased risk for breast cancer, stroke, blood clots, everyone got taken off of HRT. And so our perimenopausal, recently postmenopausal women, or even our young women who had a total abdominal hysterectomy, got taken off their therapy. And it leads to a lot of negative effects. And I want to be very clear that in that early postmenopausal, or like 48 to 60, up to age 60, you can definitely use estrogen therapy. And brain fog from low estrogen levels is someone, at least once every 2 months, I give them estrogen replacement and they feel significantly better. So, I would really think about that. And then, when you look at her as well, that you're like, oh, she's got these counterindications to hormone replacement therapy, right? She's a smoking and she has migraine. Well, that's birth control doses, right? They have higher estrogen levels. The transdermal limit, of course, the risk for blood clots, which is what our increased risk for smoking has. And then also we have less hormonal use in the HRT level. So in her case, I would use a transdermal patch, and I would use 0.5 milligrams weekly or twice weekly based on what the patch variety is as a starting spot, if we did find that. And the other question is, well, she doesn't have any hot flashes, right? Well, she's on Effexor, right? Which is a treatment for hot flashes. And then I do find that many people don't present with those classic hot flashes, but that they will have more non-specific things like fatigue, mental fog. And so, sort of what we talk about is that, you can try it for a month, right? There isn't going to be a lot of harm. And if you see a benefit, then we can persist with it. So I do think we should definitely think about that and get a free T4. And then again, comorbidities that maybe you can move on from that one because we talked about that. Comorbidities. So she did get a Cushing's value. She got a cortisol level. But again, remember, a cortisol level is a screening for adrenal insufficiency, which might be appropriate given her traumatic brain injury. We really want to screen her for Cushing's syndrome. The appropriate testing would be a 1 milligram dose of Decadron or dexamethasone overnight with a cortisol and dexamethasone test, or a 24-hour urine collection for cortisol. And I would actually not go down that path now because it's fairly rare. But what I was taught is that if they have easy bruising, proximal muscle weakness, and then if you have dark purple violaceous stria, so thick, dark purple stretch marks, those can be pathognomonic for Cushing's syndrome. And those are the people that I tend to do more of an evaluation for Cushing's on. Only 10 to 15% of people will have those dark purple stria, but those are pathognomonic. And then those additional proximal muscle weakness, easy bruising, along with the weight gain centrally in the round face, might have you think about Cushing's syndrome. So that I would at least consider that. So
Dr. Earnhardt and Dr. Subramanian, do you, because I've read also obesity, you may want to use higher. So I've always been confused. Should I do the salivary cortisol versus the, do you have any thoughts on that?
So
I do. Go ahead.
you're supposed to have 2 confirmation tests. I have found the salivary cortisol in the literature looks great, but whenever I draw it, I get one that's mildly positive and one that's negative. So I have not found it clinically helpful in my practice. In people who are on estrogen, it can falsely elevate the total cortisol. So sometimes the 1 milligram overnight Decadron suppression test is falsely positive as well. The gold standard is sort of the 24 urine collection for cortisol. And in a high pretest probability, that's what I start with, but it is more cumbersome for the patient. What about you, Savitha?
Yeah, so typically the 1 milligram overnight dexamethasone suppression test is used for ruling out adrenal Cushing's, but I think you can use the salivary cortisol and the 24-hour urine collection as 2 good screening tests because, as you said, Dr. Earhart, you can get false positives with the 1 milligram DST. The salivary cortisol has to be done at midnight 3 times, so it's a little bit cumbersome because you have to set the alarm for midnight and do it. But in this individual, if there's suspicion of Cushing, it's not a bad idea to do it. But again, Cushing's is a very difficult diagnosis. If you're going to rule out, I agree, a 24-hour urine collection, a proper collection with a creatinine and a proper volume collection is probably the best test to do in this person. Yeah.
Great, thanks so much.
And then my other question for Savitha, I don't want to open a can of worms, is with TBI, the most common deficiency is growth hormone. I don't think I would screen an IGF-1 on her because weight itself can falsely lower it. And it is controversial about treating people who have growth hormone deficiency. And because it does have things like increased insulin resistance associated with treatment, there are some negatives as well. But I was curious, Savitha, would you screen her for growth hormone deficiency as another?
No, but I think because she has a history of TBI that was 10 years ago, I think it's worthwhile evaluating the pituitary axis. So as you said, free T4, FSH, LH, but again, she had I forget whether she had her ovaries in or not, and maybe because she has this brain fog and, evaluating her adrenal axis for the opposite, so adrenal insufficiency may not be a bad idea. Yeah, I think she bought herself with that history of TBI evaluation, but I wouldn't do an
Great, thanks so much. So I think from this great case, I think, first and foremost, collaborating with the psychiatrist, and for this patient, maybe there needs to be a thorough med review in terms of why she's on certain treatments. But I think elaborating on that, I think, asking about the night eating and binge eating by using the BED7 questionnaire, and it's built into our EPIC at the weight management clinic. We did add that into the system. So it should be a flow sheet. I also think, brain fog for me, I think about sleep apnea. I would definitely screen her for that. especially when your patients come and they're like, I'm doing everything, I'm not losing. I think that's when you really start thinking secondary causes and, Cushing's, evaluating for stigmata of that. And like Nicole had mentioned with the growth hormone and thyroid, also vitamin D. I always, all our patients with obesity, but I think for a goal for this patient, I would definitely recommend 10%. And potentially our best option, I think, from hearing this discussion today, we could maybe get her on liraglutide at least up to 1.8 to support her weight loss. And with that, does anyone else have any other final recommendations?
Thank you so much, Laura, for that discussion. And Dr. Abby, thank you so much for being here. This ends session 17 of the Cardiometabolic Echo. Thanks, everyone, for sticking around. Take care, everyone.